Dear Mr. Chairman, ladies and gentlemen, thank you for the invitation to Huse, and thank you for the interesting morning, especially to have a look on the clinic and the university. It was really interesting. And now I will give a lecture on the early onset of CRC in younger patients. We see that always the incidence and the onset is younger and younger. I cannot give you a whole answer to who, when, and why, but let us see. This is the analytic report of the European Commission, and you see that all the figures for early diagnosis, but also for the, for instance, here written in the timeline treatment, you should have a diagnosis for colorectal cancer within 30 days. That's not that easy, and especially not in young patients, as we will see. So Europe has estimated 23 million people after cancer diagnosis, so-called survivors. There's a special program for survivors. Still, cancer is the second leading cause of death, and it is increasing. In 2040, we will have an increase by 21% of malignancies throughout Europe. So let me come to this CRC, and you see here the countries in green and in dark green. These are the countries where the incidence in patient aged 20 to 39 years is dramatically increasing in the last years, and this is also shown in these lines. There are different countries. I cannot present all data of all European countries, but if you go to the EU database, you will find that you have an increase in patients being 20 to 29, never were expected to having colorectal cancer, are increasing in all countries. And this is true not only for colon cancer, but also for rectal cancer. So we have a population we never thought, we thought for some of them, but not in this totally, in all those countries, okay? What can a screening do? And in all of the countries are established screenings, and these screenings, especially in colorectal cancer, can prevent, if you find polyps and so on, colorectal cancer. So, but be aware that there is a really a difference in relative risk reduction and absolute risk reduction. And only if you have an absolute risk reduction, a screening method makes sense. And this is true for colorectal cancer. So for instance, in Austria, we have a colorectal cancer program now starting with 45, and it's really desperate. Only 16% of the Austrian people who have this for free go to colonoscopy. So there are some countries with higher rates, but you have to promote this form. So are there differences in the patients between late onset, normal onset, as we were used to know patients from 60 rising have a rising incidence of colorectal cancer, and early onset patients? Yes, there is a trend towards male patients. We have a lower median age. We have a higher percentage of synchronous metastatic disease. There is a higher rate in right-sided tumor. Patients have a better performance status. Are there molecular differences? I will show you no. And yes, we can go for more metastastectomies in patients, in younger patients, due to the comorbidities. So 25% of early onset colorectal cancer patients do have hereditary colorectal cancer syndromes, and you know, 3 days ago was Lynch Day for Lynch syndrome. Every 1 of 300 patients do have Lynch syndrome, and this makes it true for early onset of colorectal cancer, but not only colorectal cancer. They have all higher incidence rate of cancers. But if you have a 1 degree relative with cancer, you have also not having a Lynch syndrome, for which we all patients look up, have a 30% higher rate on onset of colorectal cancer. So genetic counseling is to be done for all patients have a disease under 50 years, and it's not only the MSC high or mismatch repair deficiency genes, but there are all other genes which should be analyzed in those younger patients. This is the genetic testing recommendation. Which are the risk factors for early onset? 1 in 5 patients do have at least one gene mutation found in those genetic analyses which I have shown, 1 in 5. But there are also the 4 have sporadic cancer. This means physical inactivity, sedentary behaviors, and excessive calorie intake, which gives an energy imbalance, high consumption of alcohol and processed meat, obesity, and interesting repeated antibiotic treatment during childhood, and environmental toxins. So here you can see it again. If you are sitting, if you're having a bad diet or no diet, and so on, it leads to a so-called gut dysbiosis, a microbiome dysbiosis. And if you have a good microbiome, then you have some safety reasons in the microbiome for not having colorectal cancer, meaning you have a higher percentage of apoptosis, meaning I have a inhibition of cell proliferation, your immune system regulation is better, and other synergistic effects. What does a bad dysbiosis make? The dysbiosis leads to inflammatory response. This inflammatory response is one point for the incidence of CRC. You have a bad immune response, and you can even have DNA damage. So also the modulation of cell proliferation can be focused. There are multiple publications about this fact, and there is some influence, not some influence, from my point, is the influence for this higher rate of young patients with CRC. This is obesity. Obesity is only a factor if you have a BMI, body mass index higher than 30. What is about obesity in childhood? You know, there are many children which have overweight. So if you have normal weight at 7, and you have normal weight at 13, you have normal weight as young adult, you have zero risk. If you have normal weight when you were a child with 7 and got overweight with 13, and then decrease weight again, you have no higher risk. If you have normal weight and overweight during your whole time, you have a higher rate. And if you're overweighted from childhood on, you have a 2.6 point hazard ratio to have a higher risk for colorectal cancer. What about antibiotic use? Antibiotic use should be restricted as much as possible for children. It has an increasing effect on colon and has, interestingly, penicillin, a decreasing effect in the rectum. So when you go now through from childhood to adult, if you're a child, small child, you have genetic factors. If you are going up at 7 or 10, it's especially obesity. And then 17 or 20, it is your nutrition facts and alcohol consume, and all multiplicated then when you're an adult in the end. Early onset is also, there's also gap in the knowledge about having to have the possibility to have CRC, to have colorectal cancer in younger patients, and 65% of the patients who were younger than 50 had no knowledge that they are at risk to having colorectal cancer. So also the general practitioner has to think it over, because it's really, abdominal pain is a common symptom. Rectal bleeding is makes more fear for the patients. Diarrhea is also can be done by IBD, and then you have iron deficiency anemia. And you can see now 30 days it should be from the SDU says from to the diagnosis, and in younger patients it took a longer time because nobody is thinking on the possibility that there could be CRC. If you have one symptom, it's 9.7 months. If you have two symptoms, it's 5.8 months. And if you have three symptoms, it's shorter. It's also already 4.8 months. But that's too long, and that's why younger patients presented in stage 4 in metastatic disease. So I'm coming to my conclusion. There's a rising incidence for early onset colorectal cancer. There are different risk factors. The screening should be influenced. We have it in Austria now with 45, but it could be even earlier. And please, everybody should think it could be colorectal cancer. Shorten the time to diagnosis. Thank you.